doctors generally are not good at what they don't know.
True.
And what patients then perceive as them being dismissed is actually the person not feeling confident in their message or feeling like they can't do something for the person in front of them. And I think we need to learn to say, I don't know, but I'm going to actually try to work through this with you.
Well, welcome everybody to our third episode of Endo Untangled, where we look to untangle all the complexities of pelvic pain with a series of pelvic pain experts. I am Dr. Alecia Macrow, and this is my friend and colleague Cherie Noble, exercise physiologist. And today we are talking about myth busting. So it's a really important episode to me and to Cherie, where what we would like to do is spend the next 60 minutes or so having the conversation that we wish that we could have with everybody one-on-one in clinic about the background of why we do what we do and how we view the complexity of pelvic pain. So from my point of view as a GP who looks after a lot of women with pelvic pain, I feel like there is a lot of fear and confusion, frustration in people with pelvic pain. People with pelvic pain feel misunderstood, they feel dismissed, they feel disillusioned, they feel exhausted. And I often find when they come in to see me in clinic, even before we've started talking, there is a sense of being fed up with what they expect. And I think often there might be expectations about what might be offered that perhaps I don't offer. And what might come with that is a sense of being dismissed or not heard or not understood. And I think that what I hope to achieve today is to unpack a lot of that so that when a patient comes in to see me about pelvic pain, they've got a bit more understanding about why the appointment might look how it is. And also hopefully we can understand each other a little bit better. Cherie, from your side as an exercise physiologist, I think you probably get to spend more time with patients than me. What do patients come in thinking endo is and what surprises them?
Yeah, that's a really good question. I think you brought up some really good points there. I think by the time a lot of these people get to allied health, they've really been in the system a while and they've had those experiences that you've just brought up about feeling dismissed, feeling like it's in their head, feeling like they're being dramatic, thinking like, what's the point of this appointment? Like you're just going to be like everyone else. And there's a lot of information. They feel overwhelmed with the information, I think, because as we know, it's such a complex, there's so much complexity to this, as we've talked about in other episodes with, you know, what these people have experienced and what continue to experience and all of the complexities that go with the symptoms that they are experiencing. So they often come in with, I just need to have surgery. Their understanding is I've got this tissue where it's not meant to be, and if I can just get that out, then that's going to fix everything. And why are we, or I've been told that I've just got to go on the pill, or I've just, you know, and there's a sense of all these things that sometimes not through the fault of the practitioner but maybe there's just this miscommunication around I'm being told what's going on with my body and I'm being told what I need to do with it as well. And like, yeah, and I think that they just get overwhelmed. And as we know, when we talk about zooming out in that bigger picture, is when we're feeling overwhelmed, it really diminishes our ability to take in information. So, you know, maybe that's something that does contribute, but you know, I can get on my soapbox about this and it is that zooming in, zooming out concept. But hopefully that kind of makes sense of what I'm seeing once they get to me and how we can, you know, I hope this episode can help people, both practitioners and patients, be able to communicate a bit more effectively.
Beautiful. Well, to open up our discussion today, we have two pelvic pain titans with us, really. We're so lucky in Adelaide that really we have some of the biggest and brightest pelvic pain minds here across clinicians, across specialties and in the research space as well and in the development space as well. So without further ado, let me introduce Associate Professor Susan Evans, who is a gynaecologist and a pain medicine physician and researcher based in Adelaide. She is the founder and CEO of Alecia Biotech, a company developing innovative treatments for pelvic pain, and the chair of Pelvic Pain Foundation of Australia. She has a PhD in the neuroimmune mechanisms underlying period pain, pelvic pain and endometriosis, and has been a leading advocate for improved care and education in this field. Susan co-developed the Periods, Pain and Endometriosis Pep Talk Schools program and authored, well, the Pelvic Pain Bible, if I can say it. It's in all of our consult rooms, Endometriosis and Pelvic Pain, and there's a new book on its way too. And in 2023, we were proud to see that she was a finalist for South Australian of the Year. We also welcome to our podcast Dr. Carmel Reynolds. Carmel Reynolds is a general practitioner in Adelaide with a special interest in women's health, sexual health and persistent pelvic pain. She is the chair of the Adelaide Pelvic Pain Network and a clinical educator with the Pelvic Pain Foundation of Australia. Her practice focuses on providing multidisciplinary care for women experiencing complex pelvic pain and endometriosis. Susan, Carmel, welcome to the podcast.
Thanks for inviting me.
Thanks so much.
Let's find out a little bit about you both. Susan, what first drew you into working with pelvic pain and endometriosis?
Oh, it's such a long time ago now. I can barely remember. But I do know. Women's well-being and their ability to live their lives to their best potential has always been important to me. Now, at the time when I finished my gynae training, laparoscopic surgery was all I really wanted to do. I wanted to be the best surgeon, and back then we had the maybe naive belief that if we could just get our surgery right, that we could fix pelvic pain and everyone would be happy. And so that was at that time. And after a while, I started thinking to myself, Susan, you're actually getting pretty good at this, but not everybody gets well. And so I started stretching myself and learning outside the traditional bits of gynecology. And the more I learnt, the more I realised that it was a bigger picture than I'd thought of before. And it was about time that I put some effort in and learnt better how to manage the big picture.
Susan, was there a patient or a moment where this work started to feel personal to you? Would that be a fair question?
There were many patients over the years that I really thought, I'm not sure what to do with you. I had better learn some more. One interesting thing is that I actually learnt a bit from my own pain experience. So I prolapsed a disc in my neck in 2003, and that was a very interesting experience. It's not pelvic pain, but it is a complex pain where you get a lot of symptoms and a lot of different types of experiences. And the surgery I had for that was very helpful, but you don't get a new neck and not everything got better. And I started feeling some symptoms and things, unusual feelings. And I thought, gee, some of my patients have described their pain in some of these ways. Wow, how interesting is that? And of course, it was when I was recovering from that surgical procedure and I had 3 months off that I started writing the endometriosis and pelvic pain book.
Wow.
So that was a sort of a big turning point for me back then.
Comes from a really personal space.
Really personal space.
Because it's pretty confronting when pain comes and doesn't go.
Yes, it is indeed very confronting.
And being on the other side of the desk that I've heard you talk about sometimes where you can lose independence and agency, and coming to that desk as a surgeon probably puts you in a much different position to some of our patients. But even still, was there disempowerment? Did you feel, was there frustration, disempowerment?
Oh, well, most of the time before my surgery, I was just in so much pain I couldn't stand. Mm-hmm. And I recognised how little information goes in when you are in pain. So that was an interesting experience. I also realised how much you can worry about even small things happening after my surgery. I would get little twinges of things and think, what is that? What's happening to me now? Have I got another prolapse? What's happening? All those things. So I think having to learn about how to manage my own pain over what's more than 20 years has always been a learning experience for me.
Carmel, you come to this desk with a slightly different viewpoint as a GP working with all sorts of different women, including women suffering with pelvic pain. How did you end up in this part of medicine?
Interestingly, by luck. I grew up in rural WA. I had done my DIPOBs after I graduated, and then I never sat the exam. I disappeared overseas, and while I was doing it, I also did my family planning sexual health certificate at what was FPWA back then. Came back and I was a rural GP, and I would arrive in new towns with 200 outstanding pap smears as the only female doctor for several towns, so, for hundreds of kilometres sometimes. So by default, despite having very strong interest in emergency medicine, became someone who was doing a lot of women's health. I then moved back to Perth because I fell in love with a guy who lived in Perth. And interestingly, he is a pain specialist as well as an anaesthetist. So I sort of had this pain medicine thing around me all the time. And then I worked at family planning, and then we moved to Adelaide, and I had 3 babies in quick succession, and I didn't really know anyone or have any kind of professional network. So I was a bit lost. But my husband happened to be working with Dr. Susan Evans.
Oh, wow.
And I think perhaps probably complaining about me, but neither of them will admit to that, going, she just doesn't know what she wants to do. But I also had the very fortunate good luck of meeting Dr. Jane Woolcock at kids' birthday parties, because this is Adelaide, which was fantastic. And then out of the blue, I got a phone call from one of my greatest mentors, Dr. Claire Fairweather, saying, would you like to come and join us? And then it took off from there, really, which is, yeah.
So was this the beginning of the pelvic pain clinic that was open in Adelaide?
No, so it was just as Susan had finished up consulting.
Yes. I took different paths in 2017 and shut Pelvic Pain SA. It was a hard decision, but it was the right time because that was a multidisciplinary clinic. So, and I think out of that, different things like the Pelvic Pain Network and that have come to pass. And of course, Jane Woolcock has got a great clinic in ONG, and many people became interested. So it's all sort of evolves, doesn't it? And when you all work together and all support each other, it's amazing what happens.
Absolutely.
I got to sit at a table with Meredith Craigie. I got to sit at a table with Trish Newman, and it was really, really good luck. And I was really flattered and excited to be in this room full of amazing women. Tonya Mazzini would be the other one.
Again, talking about all the titans in the pelvic pain space in Australia, most of them based in Adelaide.
A lot of them are here.
Yeah, that's right. Yeah. That's right. Can you tell us a little bit about the Pelvic Pain Network, Carmel?
So we are a multidisciplinary team. We meet up once a month, and it really falls in 2 parts. Well, 3 parts. So there's a lot of support. It can be difficult work to do long term. It can be quite emotionally draining. It can be quite taxing, and there is a sort of feeling like you're not helping enough, whether that's enough people or doing enough for individuals. And I think having people that you can talk to and sound off and see where you're going in terms of your work is really important. There's an educational component. So we do have different talks that different members do, and then there's a case discussion component. So it's a fantastic group with psychologists, physios, colorectal surgeon, intermittently urologist as needed, gastroenterologist, physios, have I mentioned? I think I've got everyone, GPs. So it is a really, really good team.
Okay, let's get into some nitty gritty. I think perhaps if you wanted to pose the first question, Cherie.
So to Susan, what is the mechanism by which endometriosis causes pain?
That is such a fantastic question. I don't think we have the full answer yet, but I think we're getting closer. In the end, it depends who you ask. If you ask me, which you are today, I can tell you what I believe. I believe that this condition that we're talking about, endometriosis and all the symptoms that go with it, is really a syndrome. It's a whole body systemic experience that can present in many different ways. And one of those ways that this condition, this medical condition presents, is that it can present with endometriosis lesions. In other words, the things you can see in the pelvis. But that is not the whole thing. The whole thing is the medical condition, and you don't have to have lesions to actually have symptoms. So I think it's a lot quite similar to polycystic ovarian syndrome. Now, when I was younger, it wasn't PCOS, it was PCO, and they were funny-looking ovaries in people that didn't always find it easy to get pregnant. But then as we've learnt over the years, it's now high cholesterol, increased diabetes, maybe you're hairy, maybe you've got pimples and things, but not everybody has to be hairy and not everybody has to be overweight. So there's a mix of symptoms that cluster together. And I think that's what we have in this sort of syndrome that we see. We see that dysmenorrhea is the commonest symptom, and endometriosis lesions are common in that group, but you don't have to have them. But there's all the other things too. There's the irritable bowel, there's sometimes the overactive bladder, there's the pelvic muscle pain, there's all the other symptoms like the fatigue, poor sleep, anxiety, low mood, nausea, dizzy, faint. So to me, that is the syndrome, and you get a mix of different syndromes.
There's a lot, isn't there? Yeah. And it's you don't have to have all of them. You can have all of them. You can have some of them. And you mentioned that, if you ask you, this is what, your definition or beliefs are, but not everyone, has the same consistent message. Do you think that adds to, how patients are feeling?
Yes, I do, because it's very confusing for them. And if you ask, for example, with period pain, what period pain means, if you ask a gynecologist or a medical practitioner, they think of endometriosis lesions or the uterus itself. But if you talk to a woman about what's her period pain, she talks about her whole experience. And her whole experience might be everything from feeling fatigued or altered mood to spasm of the pelvic muscles in response to the period. It could be bowel changes. It's the whole thing. So there's this disconnect between the two.
And I think that's where some patients may come across as feeling like they're being dramatic and they get a sense of not being heard and potentially being dismissed. Do you think that is still an issue in the medical system, and how can we address that?
I do think it's an issue because I don't think anybody's particularly trying to be mean to patients or do the wrong thing. I think it's this lack of understanding on both sides and so much misinformation, which is why it's such a pleasure to be here with you today. There is no health training that anybody does where they come out with all the skills required to manage all the bits of that syndrome that we talked about. So nobody comes out with everything. So when someone comes to them with a mix of symptoms that maybe they haven't been taught much at all about in their own training, they'll handle the bit that they think they can do. If you go to a gastroenterologist or you go to talk about your bowels, you'll get a bowel treatment. But that's not the whole thing. And women are wanting the whole thing treated, and that's what they're not getting. So they go to lots of different practitioners and each one does their best, but it's a lot of misinformation, very confusing for people, and they don't really find someone who does it all for them.
Mm-hmm. Carmel, do you find this as well?
Yeah, I was just listening to what Susan was saying, and two things really struck me with that. One is that doctors generally are not good at what they don't know.
True.
And what patients then perceive as them being dismissed is actually the person not feeling confident in their message or feeling like they can't do something for the person in front of them. And I think we need to learn to say, I don't know, but I'm going to actually try to work through this with you.
When I think about that and what we've talked about as personal experiences, I actually find that it actually makes me feel more confident in the practitioner, the fact that you've said, I don't know, instead of, I guess glossing over it or thinking that you're doing the right thing by me as a patient. But the fact that someone said, I don't know, but let's work through this together. Let's make sense of it. We talk a lot about sense making and wayfinding because we're all here doing the best that we can. And with you, like you said,
and we don't have all of the answers.
Yeah,
we don't have that information yet.
Can't.
And it's evolving, and we will find more and more answers. But at the moment, we don't.
And don't you think that's the most important thing? Is that I'm here partnering with you. I'm listening. I don't have the answers, but we're going to try and figure it out.
But these are the things I can help with. The other thing that worries me as a GP is how early people go into subspecialist training now. And I do think we've lost practitioners who can really sort of step back and see a big picture. You know, they can narrow in on the one thing that they know really, really well, but it's a long time since they've looked at a whole human and tried to actually work out how it all fits together. And it worries me that we're heading further and further down that path.
We could really take this down that rabbit hole.
But I was going to say, I mean, it is something that I find myself increasingly on my high horse about, is that when you think about something as complex as this, or as so many other things that we deal with in our little rooms in general practice, is that as a GP, we're really uniquely positioned to really deal with some of these complex things in a way that some of our colleagues aren't, who are specialised in different areas. And I do think it was just one of the comments that one of you made was about, I don't know, but I'm willing to work with you on it, is really important. I don't know and I'm going to send you to someone and I don't want to see you back isn't always an answer for someone who's dealing with something so complex, because, yes, I can send you to this person who can help with this one part of the elephant, but there's all these other parts of the elephant that a patient and the GP are really ideally suited to work on together. So it's like, I don't know, I'll find out. I'll bring in some other thoughts and we're going to work together and we're going to stick with it together. And
I think now I've learned to explain to people the conversation I'm having in my head, because I say, you know, look, this is our next step. But then I don't actually explain that actually there's step B, C and D in my head. And now that I've learned to verbalise that, I actually think it's a much more useful interaction.
Yes.
So, well, if this is not the path we need, there is a backup plan.
Yes, that's right. And I think that is, as a GP, somewhere that we can go wrong is that we aren't always sharing the 9 channels of things that we're thinking about all at once. Yeah. And if someone gets offered plan A, as you say, they might think that the plan stops at plan A and there's nothing else. But I agree.
It's
in my head, there's a huge amount of stuff going on in the background that we probably aren't sharing with our patients.
Yeah.
So that is an excellent segue onto the next sort of part of this episode, which is where I wanted to bring some of the common pieces of feedback, some of the common comments that I see and that I hear, and that I wanted to put to the panel to get your thoughts on it. I occasionally do look at some of the online forums.
It's very brave.
To your detriment.
Yes, I do, and I shouldn't. I don't always know that it's a good thing, but I am really curious to know this is something that Susan talks about a lot, which I love, is the, you know, both sides of the desk. And I am really curious to know, what are the conversations happening on the other side of the desk? And I feel like if I didn't delve into that world sometimes, I really wouldn't know. And I think often as health practitioners, we spend a lot of time with other health practitioners and we don't often hear those other stories. And so one of the first concept that I wanted us to discuss is about hormonal management of endometriosis and pelvic pain. So if I was to look at a forum, there will be a lot of conversation around, I went to the doctor, I was exhausted, I got my courage together to see this new person, and then they just wanted to put me on the pill, or they just said I should have a Mirena, and they didn't want to talk about anything else. And so we're really hoping to have a conversation today about what does the other side of the desk look like? What is in the back of your mind as a gynecologist or as a GP when you're having a conversation with someone about pelvic pain and you want to discuss a hormonal component to their management? And I guess I might start that perhaps with a question to whoever wants to take it, is why is that considered to be such an important part of the conversation?
Well, I believe that the problem with this syndrome, or whatever it is, this collection of symptoms, involves the immune system, hormones and the immune system and periods, those 3 things. And every period is a stimulus to the immune system, And when the immune system becomes overactive, our central nervous system, our brain, our pain, our mood, everything about us gets overly stimulated and causes trouble. So in this group of people with this syndrome, I believe that they have just too much of that immune stimulation, and we should do our best to cut down on that so that their system isn't overwhelmed and making them feel bad. Now, we've all learnt about the fact of things that can stimulate that. Being sick with a virus or something stimulates our immune system and we feel bad. We know that if we don't eat well, our gut complains, stimulates our immune system and we feel bad. But a major problem stimulating the immune system in women is periods. So, and we know ourselves that's the worst time of the month for people, at period time. It's stimulating their whole body system via the immune system. So unless you actually tackle turning down periods, you're not going to get very far. Mm. You're just not going to get a success in managing pain unless you can get a handle on the periods. Mm. And if you want to stop periods or lighten periods, then you have to use hormones.
And I think if I can just jump in there, because and I know we've talked about this a lot, but I think people need to hear the same thing sort of repetitively around, but aren't periods natural, and isn't it, I feel like suppressing periods are detrimental to my body because it's a natural part of life and it's not something we should intervene with. Like I guess I hear that a bit as well. Is that something that you hear as well?
I'm having a sort of internal turmoil here because I do have two hats, and the other hat is my menopause hat, where I hear the exact opposite messaging. Right. So I'm dealing with one group of people who have a lot of misinformation about the potential harms of hormones, and then another group who are being given misinformation about, I should take that back. It's not all misinformation, but they're being misdirected in some ways by hormones being a panacea for all things. Mm. My hat's switching all day. But it is really tricky because if, and I'm reluctant to this, but if we go to societies where there isn't easy access to contraception, and I think contraception has been labelled in a way recently that I think dismisses what it has done for women. In terms of economics, education, family planning, it's done amazing things. And women progressed more after the advent of the pill than at any time prior to that because they could make choices. But with that choice came the option of having a lot more periods than what our grandmothers would have had. So it's not normal to have this many periods. We haven't evolved to have this many periods. It's actually a very, very different scenario to what happens in countries where contraception is not readily available. You hear stories of people who've had 3, 4, 5 periods in their life. They've also had 14 children, which is not what I'm recommending. But it contributes to bias across our health system. There is an argument that the lower haemoglobin level that's accepted for women is actually not related to anything other than the fact that we lose blood regularly. So I think it's tricky to undo the misinformation. I think we dismiss the benefits that the pill can offer. Is it perfect? I say the pill, any hormonal therapy. Are they perfect? No, they're not. Do I wish I had some way or some treatment that would intervene in the immune system that would turn this off and prevent disease progression? Absolutely. I don't have that. What I have at the moment is the potential to reduce symptoms and to prevent the syndrome from getting worse. Mm. And I have to find the best fit for the person in front of me. These are choices. They're not things you have to do. And they're one arm of our treatment. This is a multifaceted disease that needs multifaceted management. One arm of that, and I think really the driving arm, is that we need to turn off the trigger that is making this worse.
Mm-hmm. It's tools in the toolkit, isn't it?
Tools in the toolkit.
I don't know whether like when you were talking about that and thinking about that, I was thinking about it in terms of that, a plumber trying to fix the tap, like they're going to have to turn that water off.
Turn the tap off at some point.
So that then you can use the other tools in the kit.
Yeah.
Effectively.
And none of them are perfect.
They're not.
And it's about finding the best fit for the person in front of you.
And that's the thing, that's the message that I hear from this amazing panel of experts in front of me is you know, that you have this knowledge and expertise and you listen to your patients and are having these clinical reasoning discussions in your head while these people are in front of you, and have all these different tools available that you are providing the person to make an informed and educated decision about their health.
I guess one of my big wishes, this is where I'll get on my soapbox, is it would be great if all of those hormone therapies were on the PBS and there was a true choice for everybody about what was the best fit for them.
Definitely. And interesting that you bring up the iron as well, in that I was reflecting on as a GP in my practice in the last 4 or 5 years, how many iron infusions have I done on women and how many on men? And I can think of 2 males that I have
Two more than me.
with iron in the last 4 or 5 years, and hundreds of women, and even the women that or those assigned female at birth, that we recommend oral iron supplementation. Cannot think of any men that I have recommended that for, and it is another tax on women. It is solely for women, those managements. And you're right, oral iron, not cheap either.
Not perfect, not cheap.
Perfect either. No, definitely not perfect, but has a role. It's about $30 a month at least. And an iron infusion, you're talking hundreds of dollars, and that's, again, something that isn't covered on the PBS, and I think that is worth thinking about. I do certainly recognise that we are in a political time where there is increased resources being made available to women, but it's not an even playing field yet. Yeah, totally agree. One of the other, I guess, if we're talking in this space, I think it's worthwhile talking about what's out there in terms of ideas. The other idea that I have come across a few times that I've had put to me and that I've also read and seen online is the idea of the menstrual cycle as a vital sign, the 5th vital sign, that if it's a healthy person and a healthy period, then that is important, and then we must support that.
I love that if it's normal.
Yes. Can you tell me about that?
So I wouldn't look at someone's blood pressure that was not normal and say, well, you know, but it's just really important we watch and monitor this. Yes. So why would I do that with the menstrual cycle as a vital sign?
Yes.
So, yes, regular periods when you're not on hormonal contraception are important. Long periods of time without a period, without hormones, is an alarm signal that there is something going on that we need to intervene. But if we have you on hormone therapy, then there is actually nothing dangerous or wrong or unnatural about not having a period ever.
Yes.
Would be great.
It's fine with me.
Yeah.
So, and that is something that I have said to my patients who've put this to me, is that that's great if it's not harming you. So if you have a pathological process that every time this happens, you are having more damage done and it is winding up the system, is that a place that we want to be? And I think that's not helpful. And I think you're right. I think there's a really important nuance around, that's great if things are going well. If it's not, we actually really need to just sort of take a step back and think about what's the best thing for the whole system. Because I've certainly come across people who really are avoiding some of these treatments because they think that it's unnatural, unsafe.
Or the other one is that you haven't worked hard enough. So, you know, if you do my diet and my exercise program and take my supplements, then your periods will regulate. And there's so many gaps in that, and most of it is that you have not tried hard enough.
Yes.
And that's, if you're one of these lucky people who has a period for 4 to 5 days, every 28 days, it doesn't cause you to miss out on anything in life. You sleep through the night, you go to work, you go to school. Great. That's good. It's probably not the exercise you're doing, what you're eating or what supplements you're taking.
I think also that there's so many different symptoms that people are going to have to do a few things to be well. They're not going to ever really get that one treatment is going to fix everything. But if you had to pick one treatment for most people, it would be get a handle on the periods. Everything else is beneficial as well. But I think the getting a handle on the bleeding and the menstrual pain is usually the big first step in whatever way suits best.
Mm. So I guess I'll put this to both of you. Is there a way that you do hold space, or how do you approach it when your patient is cautious about introducing hormones into their care, while still trying to ensure that you're looking after them in a way that's appropriate?
I'd want to know what their concerns actually are. And sometimes it's side effects they've had with hormones before. And sometimes if they can explain what those problems were, we can find a way around it.
Mm-hmm.
You know, if it was an estrogen-related one and they got bad headaches, well, we can pick something with progestogens only. If it was that they feel flat, well, you know, there's ways of getting around that as well. This gets on to another thing that I do think is underutilised, and that's people ending up with a low testosterone. So I think that has got a lot that contributes to the flatness. So, you know, that's something I know I wasn't scared to provide for people that had got good control of their periods on hormonal treatments but then felt flat. I think the low testosterone is something that hasn't been investigated sufficiently. But I think it depends on whether you can find something that suits. If they do want the lowest hormones possible, then that's where an intrauterine device is the go. You know, Mirena, Kylena, that's where they provide benefit at the lowest hormone dose. So I guess it depends on people telling you what is actually their concern and then finding the best option you have.
So it sounds like there's responsibility on both parties of the practitioner asking enough questions and the right questions, and also the patient, you know, being forthcoming with what their concerns are and what's going on, what's their fear around this, or what have they experienced. And do you think that that's sometimes what gets in the way, is that maybe the practitioner may not be asking enough questions or thinking about things in depth, and also the patient not understanding what they need to provide?
I think there's a responsibility on both sides, and it's a responsibility of people to learn a lot themselves from good information sources. The concept that you can go to a practitioner and just sit there and do nothing and have things done to you, I think is a lot of the problem. And that's why some people just keep going back for surgery. They think someone will fix me.
Yeah.
When really, to be well in this complex situation, you actually have to learn a lot yourself. You've got to be prepared to do several different things at once, and you have to be prepared to work with your practitioner. And I do believe that the GP is the centre of care, absolutely the centre of care. You have to be prepared to work with them over a while to work out what suits. There's a practitioner in the US called Curtis Nickel who cares for male pelvic pain. And they don't have periods, they don't have endo lesions, they don't have menstrual cycle. But otherwise, if you talk to a man with pelvic pain, their symptoms are so similar. And his great quote is that monotherapy is a recipe for failure. Doing one thing and expecting you're going to be fabulous, well, it ain't going to happen.
Absolutely.
Listening to where this was heading made me think of two things. One of the benefits I have as a GP is time, in that, you know, I can bring people back, I can review what's worked. And I think anyone who's sending someone away for a script without a plan for follow-up, it's doomed to fail most of the time, because there's always some nuance in the hormones and there's always some nuance in what you can do. I try to do one or two things at a time. In my head, I want to do 23 things at a time, but then I won't know what's worked and I won't know what hasn't worked, which is the other issue. I won't know what the side effects are. But I let people know up front that we've got loads of options, and I get them an appointment on that day to come back and talk to me again in 3 months and give them the space to actually tell me what has and hasn't worked. You know, and it is tricky when you're running late, when they've somehow managed to squeeze in on a short appointment and, you know, and nothing's worked and it's all a disaster. That doesn't actually give you a lot of time, but you do have to take that deep breath and go, okay, I need to give this person the time and the space they need to actually talk through what has been happening for them, but have a follow-up plan.
Such a huge topic for me. Like, it's something I see every day. And I really hope that this little segment will be something that I can refer my patients to because we don't always have 20 minutes to talk through this, and I hope that this will be a useful resource.
Yeah, and I think it's good to have it like this as well, where you can pause and just think about it and actually go back and think, I might just listen to what they've just said again.
Yeah.
Because I think that in appointments as well, when you think about a patient, you're hearing a lot of stuff and you're talking about a lot of stuff, and, you know, then you walk out and go, oh, that was a lot. Like what did I grab hold of?
Yes, absolutely.
Yeah.
All right. So my next area that I wanted to tackle today was about the symptoms that sometimes the people I see will attribute to something quite specific in their body. So I'm talking about sharp stabbing pains. And so classically someone will come in and tell me that they'll point to a spot on their left or right lower tummy and say it's the ovaries. It's the ovaries that are hurting. And then there'll be sharp or stabbing leg pains, back pains, bottom pains, vaginal pains, and Cherie and I have talked about in previous episodes around the concept of sense making, and that's what our patients are doing a lot of, is that they're trying to make sense of these symptoms which seem not to make any sense. And so I wanted to have a talk about how do you as clinicians approach someone who comes in and talks about stabby pain. So I've got a couple of quotes here. I've experienced a sharp pain in my right ovary area that comes and goes in episodes for over 3 years now. It's like a sharp stabbing pain. It hurts more when I sit or am walking. And the next one is, I had a cyst on my right ovary. The pain was dull aching, like a stabbing pain all around my back, stomach and sides of my body. Susan, I'll start with you. What do you think? What's going through your mind when you're hearing those sorts of stories?
Well, I always divide their symptoms up. I actually get them to make a list of what symptoms they have, because there's often a few. So my first question would be, do you have one type of pain or do you have a selection of pain? They've almost always got a selection. Mm-hmm. And I say, so what's your worst pain? And that's when they normally bring out the word stabbing. Mm-hmm. Now, I then divide up their symptoms and work out where we are in the pelvic pain picture. So first of all, there's the things inside the pelvis. So that's the pelvic organs, that's uterus, bowel, bladder, and endometriosis lesions, those things in the pelvis. Then there'll be the secondary muscle reaction to what's happening there. So these are the pains that are in the muscles inside the pelvis they can't see, and they're reacting to things happening in the pelvic organs or endometriosis lesions there. And then there'll be the nervous system, the central nervous system. So there's pretty simple questions you can ask people to work out where they are in that. But the sharp stabbing pains, which can be on one side or both sides, that make someone want to curl up in a ball, they love their heat pack, they find it harder to walk, it maybe goes to their back or into their hip or down the front of their leg, that almost always means a secondary muscle reaction to things that are happening. And the big muscles that are often involved is obturator internus on the inside of the hips. So, and once you explain that, where those muscles are and how they control the hip joint from the inside, people just suddenly get it. They think, wow, okay, so I know I've got things inside my pelvis and maybe it happens more at period time or with different movements of that, but then I'm getting this muscle reaction. I'm getting a cramp on the inside of my pelvis. And then they totally get it. And of course, the thing that's controlling everything is their central nervous system. So I would be explaining the big picture there to them and how they're interacted and say that's a neuromuscular pain. It's probably not your ovaries.
It's really tricky, isn't it? Because there's a lot of confirmation bias here. So they present to emergency with this pain picture. The person they see may not necessarily have the knowledge of that. And then they get an ultrasound, and cysts are common. Right, cyst acts, and so then they have this ultrasound that shows that when this pain was there, they had a cyst, and then everybody's happy because they've identified the cause of the problem. Whether or not they've actually managed the problem is a different story. And then that confirmation bias continues. Mm-hmm. And you see this with people who will present in that situation who have repeated laparoscopies for this cyst on their ovary. And there's further confirmation bias. I think having a model on your desk to show where these muscles are is really important so that people can see. And I think and people understand that muscle pain hurts and it hurts a lot. But then it often coincides with terrible obstructive defecation as well. So that makes the left-sided pain worse. So trying to actually unpack all of that and explain where it comes from, I think, gives us a lot more success.
I usually find that if I ask people about their symptoms chronologically, like what was your first pain? And, maybe you had bad periods, but you were right well the rest of the time. And then over time, can you think of a time where it went from periods and feeling well to pain on more days and maybe a different variety of pains? And often they can remember a time in their life when that happened. And I say, well, this is when different aspects of the pain started to get involved. And when you can explain to them what's actually happened during their life, I think that's when they really believe you and they really think, okay, so this person understands my big picture and now we can work on the different things for the different problems that have accumulated over time.
Carmel, you brought up about the confirmation bias and the, lesions, which, hopefully I'm not skipping ahead here, but I think we need to talk about the focus on surgery and, that this is some panacea if I can just have the surgery, or maybe they didn't do it right, maybe they didn't get it, all of it this time, next time it's going to be, that's it. And then I'm going to be fixed if I just get the surgery.
If I just get the right surgeon.
Right surgery. Like, this is the answer. Why won't they do surgery? It's almost like you're withholding.
I need to clean everything out.
Yeah.
Your
clean it
pelvis
up.
is not dirty.
And then I'm going to be fine, and they won't give it to me.
I always have to, when I have these conversations in my head, calm the voice that says, but what if they didn't actually have a good surgeon? Because I do think we should be using subspecialist endometriosis surgeons where we can. And I accept that that's not actually available to everyone everywhere. But in my mind, surgery is for when good conservative management has failed. Now, that's not discounting that there are some people out there who, despite really good conservative management, who've had good surgery, for want of a better word, do get recurrent deep infiltrating endo. That happens. But when I talk about conservative management, I'm talking about the combination of, have we suppressed periods? Are we treating neuropathic pain? Have we looked at things like fear avoidance with food, movement? Are we seeing a psychologist to help with pacing and management of this pain? Do we need a dietitian? Do we need someone to actually guide movement? So do we need a separate physio? Do we need an EP? And I also see that as a really important part of prehab. We talk about prehab for so many other surgeries. And I think going into what is a painful procedure, it's not a laparotomy, but it is still painful, without any of those things in place, I think is harmful. And with no plan as to what you're going to do on the other side.
Susan, how much surgery is too much surgery, and when does surgery become counterproductive?
That's a really good question. One of the things I think is that people shouldn't think that surgery is the first thing. It should be, even if someone is going to have surgery, like maybe they've got symptoms or family history or something that suggests that there may be endometriosis lesions there. It's not unreasonable to have a laparoscopy to assess if the symptoms sound reasonable. But there's so much you can do beforehand, and the outcome of the surgery will be so much better if you do those things first. You get better outcomes, you recover quicker. So I think that the surgery, if the first laparoscopy is planned, that can be planned, but there's no big rush because there's so many things you can do beforehand to make it go better. So, if I was someone with complex pelvic pain that involved severe dysmenorrhea, I would probably anticipate that at some stage a laparoscopy may be reasonable to assess the pelvis and remove endometriosis if it's there.
And just to interrupt there, dysmenorrhea for the non-medical listeners is very
bad
painful periods.
Painful periods.
Yep.
Now that is changing a bit because I think nowadays with really high quality ultrasound and AI and MRI and things, that will change. It won't necessarily be that as many people go, plan surgery, because you'll be able to exclude bad endo with scans You won't be able to find minor endo, but minor endo you might be able to manage in other ways. Sorry. So what I'm saying is manage as many symptoms as you can first while you are in the process of thinking if you need a laparoscopy. Now, if you've had a laparoscopy when you are young, sometimes not all the endometriosis lesions have shown at that stage. And most endo lesions form in your teens and 20s. So if you have had a laparoscopy which found some endometriosis at a fairly young age, like, sort of teens, early 20s and things, it's not necessarily unreasonable to have another one later on. But I do think you should think carefully before any surgery. Is this necessary? Is there another way? Because all operations can stir up your immune system and your central nervous system. And there's plenty of people who felt worse after surgery.
Mm. And Susan, I'm interested, just from your history background as a surgeon, is we've talked about hormones and hormonal suppression of periods and quietening down or putting those cycles to sleep. In your experience, could you notice a difference in someone who is having a laparoscopy who has been on hormonal suppression of their periods over a period of time, perhaps since a prior one, compared to someone who's not been on?
You mean the look
suppression?
of the pelvis?
Yeah. Can you
No,
tell
not
the difference?
really.
Okay.
I guess the endo lesions are either there or they're not there.
Yep.
And once you get reasonable at picking what's an endo lesion, and if you're comfortable removing things, in other words, endometriosis surgery is your thing,
Yes.
then I think you can do it at most times. But what we do know is people that have a laparoscopic excision of endometriosis and suppression of their periods are less likely to grow more endometriosis lesions. So people often offer a laparoscopy and put a Mirena in, for example, or a laparoscopy and continuous progestogens to keep the periods away. If you have a laparoscopy and you don't suppress the periods afterwards, you're going to be more likely to get more endo lesions and your pain's going to be harder to manage.
That's really important, I think, information for people trying to decide what's coming forward.
Mm.
So I was hoping to talk about bowels today, but I think bowels is just their own hour, I think.
Can I just, a quick question to Susan? Something that often comes up with my women in their 30s is planning timing of surgery. So surgery is something you've been thinking about as part of their managing pain, but they're also at a point in life where they're thinking about having children. And is there benefit of timing that surgery in relation to trying to conceive?
That's a tricky one. And I think it is changing all the time with the different diagnostic things. The severity of endometriosis, like how bad the lesions are when you look inside, it doesn't fit well with the amount of pain because the pain is so many other mechanisms that we've talked about, but it does fit reasonably well with how likely couples are to get pregnant. So if a couple's wanting to get pregnant, and they're not sure about a laparoscopy, I would encourage them to have a high-quality endometriosis scan. And, you can only go to a couple of places for that because that will mean that if they've got severe endometriosis, it won't get missed. And so I think that they might not need surgery if that is all completely normal. If they've got a whole lot of period pain as well, and you've got good reason to think that they might have endo, it's not unreasonable to do a laparoscopy. What you've got to be careful of is doing anything to ovaries, which might reduce ovarian reserve. I think sometimes the thoughts of a fertility doctor beforehand, if there could be troubles, can be useful.
I think there's definitely a podcast episode in that as well. We are running short on time, so I didn't want to miss the opportunity, Susan, to talk about your work in biotechnology and what you're up to. You are working on some novel approaches to endometriosis. Are you happy to share a little bit about what you're doing?
I am indeed. After all those years of looking after women, having surgery, having pain, etc., what's really obvious is that we don't have enough tools in the toolbox. And so, probably crazy, but I started trying to develop some. And if you believe that it's a whole body condition, and if you believe that the immune system is involved and that the uterus is a major source of immune activation for women, which I do, I believe all those things, then if you can turn down that immune activation in the uterus, you can impact and reduce central nervous system symptoms without drug levels by just turning down immune activation in the uterus. So that's what we're developing. So Alecia Biotech is our company developing a new intrauterine device, and it has all the normal things of normal intrauterine devices, but it's also got a medication on there that will turn down and normalise that immune activation in the uterus. And we're trialling it in Adelaide, and we'd love to hear from listeners who would like to be in our trial. So we're looking for people who've got period pain. And as we all know, there's quite a lot of them out there, but we're looking to hear from people who've got period pain who might like to be in a trial of our new device to help difficult to manage pain.
Amazing. And how can they get in touch with your people? Well,
the easiest way is just to go to Alecia Biotech. We've got flyers and things around different places, but ALYRA BIOTECH, AleciaBiotech.com, and I'm sure you'd find it if you look me up online. And there's a link to people who might like to join.
We can pop some information in the show notes as well.
Fantastic.
So great to see.
That's really exciting.
Yeah, what amazing
It's a
work
global
is happening.
first.
Yeah.
It's a world first. It's a first in class. So if this product goes well, it'll be a whole new area of women's health.
So needed as well. So needing some new treatments to offer this women in this very complex space.
Thank you.
So, and you have a new book coming out as well, which we
do
talk
for teenagers.
about. Yes.
I've got a new book for teenagers.
Do you sleep, Susan?
No. So I've got a book for teenagers coming out, which is Endo and Pelvic Pain for Teens. So it's really it's their first stage of really health literacy. So they'll be able to better engage with the healthcare system. They'll be able to talk to their health practitioner as well. They'll be that great person on the other side of the desk who's ready to collaborate with you as a health practitioner and work together to a life of less pain.
Amazing. And I think we know how heritable endometriosis is. And so I'm sure there'll be women listening who are mums of preteens and teens watching carefully what their kids are doing and what their periods are like, and certainly good to start thinking early about these problems. I often say so much better to see a 15-year-old in clinic than a 25.
So much easier.
Oh wow, it's a whole different world. And so so the more awareness there is and the earlier we start thinking, the better. And again, so many podcast episodes, but parenting an endo kid would be is definitely another conversation that I would love to have at some point.
Either of you can jump in on this one, but one message that you'd love to give, I guess, GPs and or patients, like what's the one takeaway that you want to give everyone today?
Periods that disrupt your life are not normal. And I think that's really, really important. And there is a lot that we can do about it. And if we intervene early, the evidence so far suggests that we prevent the development of a pelvic pain syndrome. Children are missing school if you can't sleep through the night, if the pain is preventing you from living your life, that's not normal.
And I'd like to say what an exciting space this is for health practitioners to work in, that there's been so little happen over so long, that there's so much difference can be made, and you can find this a satisfying career. And where you're interested, life is never boring, and you can feel like you've made a really big difference to people's lives.
What a wonderful discussion. I wish we had twice as much time. Associate Professor Susan Evans, Dr. Carmel Reynolds, thank you so much for your time today, and look forward to hearing some feedback from the audience, and perhaps we can do this again in the future. Thanks
Certainly.
so much.
Thanks for having me.
Thank you.
Thank you.